Well, we're glad to have everybody here with us, and this is an interesting topic. I'm going to just go ahead and share my screen. So this topic is really interesting. It's something, like Jason said, something that we're dealing with day in and day out as endodontists. And so we find that there's a lot of confusion and difficulty in diagnosing and treating cracked teeth. I don't know how many of you feel the same type of frustration, but cracks can cause a lot of confusion and frustration for patients and for doctors. And I think part of it has to do with sometimes the definition. Sometimes we mix up the definitions, and we'll call a crack or a fracture. And sometimes there's confusion in the literature and the way they describe cracks or fractures. There's a difference between a crack in the crown versus one in the root. And so there's just a lot of confusion. So the purpose of our discussion today would be to kind of try to clarify some of these terms and help out with the diagnosis, and then help you understand what the prognosis should be so that you can apply that in your day-to-day treatment of your patients. So when we talk about a crack, really what we're talking about is a longitudinal type crack, one that runs the length of the tooth. I think one of the things that's really important to remember is these cracks, they increase over time. They never go away. They either stay the same or they get worse. It's fair to say that these cracks allow bacteria to penetrate into the tooth. And when we have cracks in a tooth, that's a finding. It's not a diagnosis, but it's a finding. And the treatment and the prognosis for teeth that have cracks is really dependent on the location and the extent of the crack. So it seems like almost every day I'm talking to patients about a crack that I might see in their tooth, and then having a conversation about whether that's a tooth that we ought to save, or if it's a tooth that ought to come out. So really the keys to saving teeth with cracks is really, knowing how to identify and classify the different types of cracks and fractures so that we can then educate our patient and help them to make a decision. Understanding the signs and symptoms and learning to detect these cracks as early as possible, and then understanding what the appropriate treatment and the prognosis will be. Every one of us, if we looked closely in our mouth, we'd probably find several cracks. And so it's a natural part of life, and it doesn't mean that all teeth with cracks have to come out. Some of them will last for many, many years. We have to properly diagnose them so that we can determine what the prognosis is and help patients make a decision what's going to be best for them. So when it comes to identifying and detecting cracks, there's lots of different tests and things that go into that. For example, the dental history, our subjective examination, tactile examination, periapical testing, bite testing. Vitality testing is very important in determining prognosis. The perio probe is another important test in trying to determine if there's cracks or fractures in roots. Radiographs, cone beam, and additional tests like staining, transillumination, and even surgical exposure. So lots of different ways that we can identify cracks and try to determine the extent of the cracks. But I thought we'd back up here first, and let's talk about the 5 different types of cracks that the American Association of Endodontics has published. And let's make sure we can all get on the same page about what these 5 cracks are. So in an effort to make this a little bit more interactive, I'm going to invite people to come off mute and share with us what type of cracks these are. So the first tooth on the left there, what would you guys call that? Somebody come off mute and tell me what we'd call that first very thin, small crack in the surface of the enamel.
An enamel infraction.
Okay, an enamel infraction. I also like to call these craze lines. Thank you, Pam. The second tooth there, what would you call that type of a crack or fracture of the crown? Anybody want to come off mute? Don't be shy. That's a fractured cusp, okay? You can see the fractured cusp takes a corner of the tooth out, and we deal with those day in and day out. The third one, we'll just call it a cracked tooth. The fourth one is when that crack goes really south, and then we call that a split tooth. And then the last one, you'll notice it's different from the first four cracks in that it's starting apically and starting in the root as opposed to in the crown. And that's what we call a vertical root fracture. So these are the 5 types of cracks that we're going to talk about today. And I've got a lot of images to show you, and we'll talk about different ways to treat them and the prognosis. I want to make sure if any of you have any questions as we go along, feel free to jump in. If you want to come off mute and ask your question, don't hesitate to interrupt. If you want to put a question into the chat, Matt and Jason are watching for that, so they'll bring that up too. So please don't hesitate to stop. Let's talk about the origin of where these cracks start. The Kray's line starts coronally. So that's starting from occlusal forces. And, you know, if we look at most adults, we're going to find these Kray's lines in most of our teeth. All right, so then we have the fractured cusp. The origin of these, the Kray's line starts from above, and fractured cusp also start from a coronally and a split tooth as well. And the difference is the vertical root fracture starts apically from the root first. When we talk about the prognosis, on the left with this Kray's line, the prognosis is good for these type of teeth. On the other end of the spectrum, the vertical root fracture, our prognosis is poor. And the teeth in between are really somewhere in the middle. So you can see that we have a big variety of prognosis here. And so we're going to be, it's going to be our responsibility to help our patients understand the prognosis and the risks of treatment with each one of these types of cracks. And we will be helping with them. So when it comes to treatment, same thing. We've got a variety of treatment. All right, so Kray's lines require no treatment. As I said, most of us are walking around with lots of Kray's lines in our teeth. When we get down to the other end of the spectrum, the split tooth and the vertical root fractures, there are no options other than extraction. But the fractured cusp and the cracked tooth, we do have some options for treatment, and those are teeth that we oftentimes can save depending on the extent of that. So we'll talk about these 5 types of cracks first. We did have one question, most common cause of vertical root fracture. And I think it's probably fair to say that a lot of that has to do with these are oftentimes associated with prior endodontically treated teeth. But I think I've seen many times where we get root fractures from trauma as well. So those are the 2 main causes probably of the vertical root fracture. So let's talk about each one of these 5 types of cracks, and I'll show you some cases. And do we have any questions at this point that anybody wants to ask? All right, so as I said, with Kray's lines, most adults have them. They're oftentimes seen on the marginal ridge, but these types of cracks are in the enamel only. Transillumination is a useful tool, and one of the interesting things about a transillumination, the light will shine right through a Kray's line, different than it will if it's an actual crack. The treatment for these types of cracks is nothing. We just monitor them and we crown them over time if they get deeper and go through the enamel. Here's an example of the Kray's line. You can see that the light shines through the crack or through the Kray's line, but when you get to the crack actually stops the light from transmitting through the tooth. So our second type of crack is the fractured cusp. These can be complete, or they can be incomplete fractures where the patient comes in and they're complaining of pain anytime they close. And that's when the cusp hasn't actually broken away from the tooth. Most of the time there's a restoration present with a fractured cusp, and it involves, at least 2 surfaces. And extends into the cervical third of the crown. So the most common symptoms are severe pain to chewing. And if the tooth is still vital, then they're going to have temperature sensitivity as well. The treatment for a fractured cusp is, if it's still there, is to remove the fractured portion of that cusp. And it's also, like I said, important that we determine what the status of the pulp is. If it's irreversibly inflamed or the pulp is exposed, then we'll need to do the endo first. Oftentimes, depending on how far apically or cervically these cracks fracture, many times they'll need crown lengthening and a crown. So here's an example of a fractured lingual cusp. And in this particular case, if this tooth is, if the pulp is vital, this may be one where there's enough tooth structure that you might get away with just build up in the crown. But you can see that there appears to be another crack on the distal there. So once you remove the rest of the distal lingual cusp, you may want to go ahead and do endo for a restorative reason. But the pulpal status is super important in determining that. This is an example of a tooth that came in with a fractured cusp. And we could see a crack in it. Once we took the enamel out, we could see that the cusp was significantly undermined, and there was a crack on the distal as well. So these are the kind of cracks that are pretty aggressive. And in this particular case, despite us talking about the poor long-term prognosis, this patient chose to retain the tooth regardless. And so we went ahead and completed the root canal and placed a post. This was done a few years back. We used a steel post. This was a 4-year recall on this case. So, you know, in a case like this, I usually tell a patient that the most they're going to get out of a tooth like this is probably 4 or 5 years before they'll end up losing it. But I've found when patients are given that information, many times they don't want to lose the tooth and they'll choose to retain the tooth as long as possible. Here's another example of a fractured lingual cusp on a bicuspid tooth. And you can see that it shears off kind of subgingivally. And so this is the kind of a situation where you may require a little crown lengthening or at least a gingivectomy to be able to put a margin on the lingual surface of that tooth. Here's the case where we did the same type of treatment. We completed the endo, and then in this particular case, we're asked to do the buildup. So you can see where we placed a fiber post, and we've done a little bit of a gingivectomy around the palatal to get access to that tooth, and then we've started building it up with resin, and then prepped it back, and then this is the final. And the crown goes on. This is a 3-year recall. So in this particular case, that tooth's doing well, and the root canal has allowed them to save that tooth a little longer. Now, this is the cracked tooth that we're dealing with, and is the trickiest, I think, for all of us in treating, mostly because it's really hard to tell how deep a crack goes, especially just looking at it occlusally. But when we talk about this type of a crack, it's usually what we call incomplete. We see these most often on the mesial marginal ridge or the distal marginal ridge. And they start coronally and move apically. And if these type of cracks are left untreated, they can only get worse over time. I had a patient today, and we ended up having to take a tooth out that had been left untreated like this for many years. And I took the time to show him that he had at least 4 or 5 other teeth in the same situation with cracks that were untreated. And the longer he waited, he was going to end up losing more teeth. So I actually sent him back to his dentist, understanding that he needed to consider probably 4 or 5 more crowns to protect his other teeth so that he didn't end up losing them. But some of the great diagnostic tools that we'll use in diagnosing cracks is biting test, particularly if they have pain upon release when they're biting. But really, the best way I think to identify the depth of these cracks is with visualization under a microscope. And when we start the endodontic treatment, we're able to look actually and track that crack internally to see the extent. Now, if you try to prep this tooth, let's say you try to drop a mesial box and remove that crack, you can see the extent of that crack using your loupes as well. And so that's another a great way. I can't underestimate the value of magnification in making these diagnoses.
Jason,
Yes, Julia.
but biting tests with tooth sleuths, or how do you do your biting tests?
Yeah, I like to use a tooth sleuth. You can use you can use a cotton tip applicator if you'd like, but I like the tooth sleuth because it allows me to identify each particular cusp that I want to have them bite down. And like all of the other tests, I like to test the adjacent teeth as well. And I just have them bite and then release. And if they have pain upon biting or release, that to me is that's a positive result for the bite test. But that's my preference, is the tooth sleuth.
Hey, Jace, we have a couple questions real quick.
Yeah.
One of the questions that was asked is, if a cracked tooth is a finding, what is the diagnosis?
The diagnosis is going to be a pulpal and a periapical diagnosis, right? So that's really important to determine. And then if there's a crack, that's a finding adjacent to that. So, you know, we'll talk a little bit later about what the cracked tooth syndrome means, but the finding, it's a finding as in that the pulpal and the periapical diagnosis determines the endodontic treatment that's recommended, and the finding of the depth of the crack or the extent of the crack is going to play into the long-term prognosis, restorative prognosis of that tooth. So if that crack extends below the level of the CEJ, then I would usually call the prognosis poor, long-term. And when I say long-term, I mean longer than 5 years. So that's why in treating these teeth with cracks, it's really important to try to determine the best you can the extent of the crack, how far the crack goes. And if the pulp is vital, like I said, and you're planning to crown the tooth, you can't always tell. When you prep your crown, you may be able to see that the crack has been removed completely, and then you can feel confident that it's gone and you don't have to worry about it. But if you drop your crown margin and you can still see the crack, then I think you probably can let the patient know the extent of that crack, and that might affect the long-term prognosis. I always tell patients, you know, the crack doesn't go away. It's always going to be there, and it either stays the same or it gets worse with time. So here's an example of transillumination. You see how when the light shines through the enamel, the crack actually breaks the light and really creates a really well-defined change in the transmission of the light through the tooth. Here's a clinical image of, you can see a large occlusal resin, and you can see a stain on the mesial lingual of that tooth. When we remove the restoration and then we transilluminate that same crack, you can see the stain. You can see how the light stops at the level of the crack and really lights that up. So using transillumination and looking into the canal, we can determine how deep that crack goes, and then if that's a keeper. So here's a series just of different clinical images to show you these cracks. And in a tooth like this, you know, you can see this probably an amalgam that's been there 30 or 40 years, and we've got cracks from every side. Here's another one, small occlusal amalgam. These are the type of teeth that when I see them, I wish that they were crowned years ago. Okay, so if you see these patients in your practice, you know, these are teeth you need to get crowns on. I would, well, you know, I wish they would have gotten crowns on before they got cracks on all four sides. But the point being is that by identifying these crowns, you can make the recommendation for cracks for crowns before they get to this point. Here's another one where we've got, the mesial recurrent decay, but you've got multiple cracks in this tooth as well. More examples. So as I mentioned, the treatment of these types of cracks depends on the extent, the depth of the crack, and the location. You have to do your best to determine, how deep the crack goes. If the tooth is non-vital and it needs endodontics, then we have the advantage of being able to scope it out internally. And under the microscope, we can look inside the root of the tooth and we can see the crack and trace it down to the depth, to how far it goes. And then we can give them a better prognosis. The microscope allows us even to see, the depth of the crack going down into the canal orifice, or even across the pulpal chamber. So here's a clinical case. It's tooth number 3, a necrotic tooth. You can see it's a fairly large DO resin restoration, and a crack, a visible crack is noted on the mesial marginal ridge. So we start the endodontic treatment. As we're doing that, we can see the staining. We can use the microscope to see the extent of the crack. In this particular case, we can see the crack goes all the way down to the pulpal floor. So you can assume that that's probably close to the level of the crestal bone. That would make the prognosis on this poor for long-term success. So by determining the extent, we can then give the patient a long-term prognosis on this tooth is poor, meaning it's only going to last 4 or 5 years probably before they lose it. As I explained, there are many times patients will say, I don't care, I don't want to lose that tooth. And so in this particular case, we'll complete the treatment. One thing that I like to do in this situation, or I would recommend that we do as partners in this treatment, is we can put an orifice barrier down into the canal and try and create the best coronal seal. But patients need to understand that those type of treatments are short term. They're not going to last for 10 or 15 or 20 years. So just in summary, when we have a tooth that's cracked, we try to remove it. If that crack doesn't go down into the root of the tooth, we remove it, we put the crown on it, and the prognosis is good. If we have a crack like this and we ignore it and we don't treat it, then over time, it simply will propagate to the point where the prognosis is now poor and the tooth is lost. So that's great reason for all of you to get out there and start putting some more crowns on these cracked teeth. Because if we fail to do that, they will eventually cause the loss of the tooth. Here's another case. You can see a very large MO resin, and there's a crack on or DO resin crack on the mesial marginal ridge there. The tooth is necrotic, so we started the endodontics. We got inside, we could see the depth of the crack, and we talk with the patient about how far that crack goes. We tell them what they can expect, and then we let them make a decision if they want to retain the tooth or if they want to remove the tooth. In this particular case, the patient chose to retain the tooth, so a root canal was completed and crown was placed. So it's really important, I think, that we give patients the best information that we have about how long a tooth with a crack could survive, and then let them decide. Success is different for some people. Some people's success is they want 15 years. Other people, they just don't want to lose a tooth, and they're willing to retain a tooth even if it's only going to last 3 or 4 years. And in my opinion, I think, I let them make that choice. I just try to make sure they understand the choices, the decision that they're making. So Any questions at this point about cracked teeth?
Hello.
Okay.
Hi, this is Dr. Pamela Gentile. Hi.
Hi, Pamela.
I think the concern I have about cracked teeth and the diagnosis to go straight into a crown is you and everyone knows that Dr. Keith and I are fairly conservative. And, you know, in my point of view with cracked teeth, we have watched people over the years have absolutely no change in cracked teeth, or look at doing bonded restorations to negotiate the cracks without going straight into crowns, especially for teeth that are asymptomatic or things that have been, you know, stable over time. So what's your thought versus going straight into crowns, you know, where there are studies that show that doing bonded techniques that are reasonable have a good expectation for long-term as well? Because we find that we have both people that have been very stable with cracked teeth for a long time, and also when it's necessary to look at cracked teeth, maybe just doing another filling that incorporates the cracked area if it's reasonable to find. So what's your thought on that versus
Well,
crown?
that's a great question. I appreciate. They're going to think that we planned that, Pam. That your question was a plant.
No, not at
because
all. We're just really
this-
conservative.
No, this is a great point. So here's one thing that I like to show patients, and we're gonna talk about bonded restorations here too. These two studies, one in 2006, one in 2007, basically show that if you have a cracked tooth and you have an irreversible pulpitis and you crown it, this 2-year survival rate is 85%. I like to tell patients when they have a cracked tooth but a vital pulp, if they'll put a crown on the tooth, because the pulp is healthy, if they'll put a crown on the tooth, 80% of the time they're going to be fine. This 2000 study shows that 6 years, 80% were fine without endodontic treatment. So that's one important thing is about cracks. And then when we go to talking about the bonded restorations, you're right that there are also studies that show that a bonded restoration can also prolong the life of the tooth. There are so many factors I think that we have to consider when it comes to our patients. And you guys, as the general dentists who see the patient day in and day out, year after year, are in the best place to make that decision, whether a bonded restoration is going to be adequate or coronal cuspal coverage. You're going to know that patient's personality. You're going to know if they're type A, grinding, bruxing their teeth, breaking off cusps, right and left. So we really, of course, would always defer to your recommendation as you know that patient in and out. I do have a slide that shows some of those studies that talk about bonded restoration. I thought it was coming right up, but well, here it is right there. So can you see my screen now? So here are a few studies that talk exactly about that, Pam. Abbott in 2009 was the study about 80% of the time, if the tooth is vital, to be treated conservatively without the root canal. Opdam in 2008 reported cracked teeth with reversible pulpitis are restored with direct bonded resin is successful for treatment of the cracked tooth, and that's at a 7-year recall. So there's some good information or good example about a bonded restoration being sufficient. In 2007, Signor also reported a bonded composite restoration maintained long-term vitality in 93% of the cases. So there are some great studies there that support that concept of really conservative approach of bonded restorations. As the endodontist, it seems that we are seeing the teeth that end up, like I've showed, with multiple cracks in the teeth. You're exactly right that the bonded restorations can be a really conservative approach, especially if the cracks are minimal. Thank you for that question. Any other questions at this point?
Jason, I have a quick question.
Sure, Leanne, what's your question?
What percentage would you say of those are amalgam and versus large composite as far as the fractures?
That's a great question. To me, it seems like we just don't see people placing amalgams anymore. So all the amalgams tend to be so old that all the amalgams tend to have cracks, it seems to me. What do you think, Matt and Jason? Do you agree? I mean,
Yeah, I mean, it's pretty rare to see a brand new, you know, GV black type mouth that's got amalgams on every molar. So I'd agree. All of them are old, and it seems like 30, 40 years, they are very much cracked. And of course, we see those cases that are typically severe and either extraction or more extreme treatments needed. But yeah, you just don't see that.
and
Maybe
when you
it's
think
just,
of,
maybe
I'm sorry,
I
Leah,
work
go
in
ahead.
I work in a practice where it's kind of like I would say an aged population up in North Scottsdale. And I just feel like that's all I see. I just feel like we just see tons of that. And like you're pointing out, I mean, because they've been allowed to go so long, we just have a lot of endo that's necessary and a lot of crowns and, whatever.
Thank you. That's a great point. Good question. I think you guys that are out on the front lines, seeing the patients, regularly, you guys have and you understand the other things going on in their mouth, periodontally, parafunctional habits. We have to just take all of this information together and make recommendations based on where we feel like these patients are going. This next slide talks about what's called fracture necrosis. And this is a really interesting concept when we have a virgin tooth or a very minimally restored tooth that has a necrotic pulp and has a significant crack in it. This is what we are is called fracture necrosis. And essentially, it's determined that the tooth has become necrotic because of bacterial penetration through a crack. And when it has caused the necrosis of the tooth, it's very difficult. The success rate goes down. And so extraction may be considered the primary treatment option in this particular type of a case. I'm getting to the point where when I see these and I open them up, I almost always then end up recommending the tooth comes out after I've opened it up to see the extent of the crack. So again, this is what we call fracture necrosis. And it has to do with the fact that the bacteria penetrated into the tooth and caused the necrosis, making treatment prognosis poor. So you may not need to spend as much time exploring these. Any questions about fracture necrosis? The first article that I saw was in 2010, describing fracture necrosis. So, okay. Here's an example of another fracture necrosis. You can see almost a virgin tooth, and look at the size. It's an extensive crack, a large crack with staining. This is the type that it's not worth opening up. Once you open that up, you're going to see that crack goes down below the CEJ, making the prognosis poor. Here's another example, number 31, very conservative restoration, necrotic pulp. We open up this tooth and we can see that the tooth literally is broken in half. So this is really a split tooth. Let's see it going from one side to the other, right across the floor of the pulp. So this is the kind where you wish that you hadn't spent an hour opening that up only to learn that the root was split in half. So here's basically the philosophy that I use in managing cracks. If I find a crack during endodontic diagnosis and I learn that the tooth is necrotic or has an irreversible pulpitis, then I'll start the root canal so I can get a look internally, because we know it needs a root canal anyways. We'll open it up and get a good look internally. Once inside the tooth, if I can see that the crack is superficial and it's in the crown and it doesn't extend into the root, then I complete the root canal and recommend the crown, and the prognosis is good. However, if we learn that this crack goes below the CEJ and goes down into the root, that's when the long-term prognosis becomes poor. And I explained to the patient that if we move ahead with treatment, the solution is a short-term solution. And many times they'll choose to go ahead and save it, understanding that. And many times they'll choose to take it out and move on to an implant or a ridge. If we see that the crack splits the root of the tooth, then we insist that the tooth comes out. We don't spend any more time with it. If during our endodontic diagnosis, we learn that the pulp is normal, then we recommend just going in and removing the crack and doing the buildup. That would be done by you guys. You would go in and start that crown process. If during that process we find that the crack or decay goes into the pulp, then we'll do the endo. If as you start that crowning process, you don't see any damage to the pulp, then you place the crown and the prognosis is good. If over time, 20% of the time, symptoms, the tooth becomes symptomatic, then we'll treat the tooth endodontically at that point. So that goes back to the study that said if the pulp is normal on a cracked tooth, if the pulp is healthy, then 80% of the time it will be fine without a root canal. So here's another example. On this tooth, we find cracks on the mesial and on the distal. Long-term prognosis is poor. So we let the patient know that this is not a tooth that's going to last. And this is one that ends up coming out. You can see the cracks there. Here's another example of an amalgam necrotic tooth. We open it up. You can see the crack down the distal. And you can actually, in this image, see that the crack turns and undermines the cusp. Right there at that point, it undermines the cusp. So prognosis is poor. In this particular case, the patient still wanted to try to retain the tooth. So went ahead and did that. Here's one where we have a deep, narrow pocket. This is the periodontal finding that's most commonly associated with a split root. And in this case, this tooth came out and you could see the vertical crack. This is a crack you see starting coronally and working down. It's almost to the apex, but it's not all the way to the apex yet. So this is a coronally induced crack instead of a vertical root fracture, which starts apically and works its way up. So any questions at this point? Okay, well, let's talk just for a minute about what cracked tooth syndrome is. Remember, cracked tooth syndrome is a vital pulp. The tooth is still alive, but the patient is reporting pain to biting. The symptoms are fairly irregular, and you may or may not be able to see a crack, but that's what we call a cracked tooth syndrome. And if the pulp is vital, then the recommended treatment is to put a crown on it. This is an example of an amalgam that was removed. We found a crack on the mesial, and in this particular case, patient chose to save it. So this was upon completion of the treatment, and this was a 5-year recall. So sometimes we're surprised. Sometimes these teeth can last longer than we expect. So I really let the patients decide once they understand what the prognosis is, if they want to save a tooth or not. The split tooth, though, is a different thing. We don't save a split tooth. Once that crack goes down the root of the tooth, it's always recommended that the tooth is removed. And the split tooth, of course, comes because of the cyclic forces on the tooth that eventually cause these small cracks to become larger cracks, and they damage the tooth. We're able, using the microscope, to see cracks that split the tooth in half. So here's a few more images. This is a good example of a crack that isn't seen occlusally because it's below the restoration. And in the film image to the right, you can see under the amalgam, the crack is clear, but would only be seen once that amalgam has been removed or accessed through for endo. In this particular case, you can see the crack even splitting the tooth in half. And so this is a tooth that has to come out. This is another case with a root canal that was done many years ago, and the patient presents with some swelling. We can see some thickening of the ligament on the mesial root. And when we take a scan, we can see clearly that there's breakdown, lateral bone loss along the side of the root. And this is a real classic finding of a split root. So this is a case where the recommended treatment is extraction. Just playing with the 3D image, you can see that if we take a slice through this angle where we suspect the crack is, you can see the crack show up in the scan. So CT scanning is super helpful in diagnosing and treating or diagnosing these cracks. I also tell patients that most of the time we're not actually able to see the crack, but we're more likely to see the changes in the adjacent bone that the crack causes. All right, and so now we're at our final vertical root fracture. The vertical root fracture can be complete or incomplete, but it starts in the root as opposed to in the crown of the tooth. And it can extend the entire length of the root, or it can be a shorter fracture. These cracks, fractures, vertical root fractures are usually caused by wedging forces or by trauma. And that's kind of what we had talked about before. Any questions about vertical root fractures? Here's the
Jason,
clinical.
there
Yeah.
was a question. Question was, so cracked tooth syndrome would not be a diagnosis, but rather a finding. So
That's correct.
you want to answer
That's
that?
correct. I still, the way I diagnose it is with a pulpal and a periapical diagnosis, and then I add on a cracked tooth syndrome as a finding in addition to the endodontic diagnosis. So in this particular case, if you look at the image, you can see there's something a little bit odd about the way that the root canal filling looks. That you see a lucency around the apex, and even at the very around the obturation, and at the apex you can see what looks like a little crack. And so this is a vertical root fracture, and this is a fracture starting apically, working its way up. And treatment here is extraction. This is the case that I did, and it was a silver point retreat. And you know, hindsight's always 20/20. As I look back at this tooth, I can say, well, you know, I saw the widening of the ligament on the mesial, but my assumption was that it's a silver point, and it's been there a long time. So let's go in there. And we went in and completed the retreatment. Did not see any crack or fracture at the time. But just 2 months later, the patient returned, and we could see additional breakdown of the bone along the mesial. And so this was diagnosed with a vertical root fracture. This is the tooth after it came out. And I thought this was interesting because if you look apically, you can see the crack at the apex. And if you follow that all the way up coronally, you can see that it stops. It doesn't go all the way up to the crown. So this is a crack that started apically, worked coronally. And that's what we would call a vertical root fracture. So any questions about any of those 5 classifications of cracks, fractures?
Jason, I do have another question. So with the vertical root fracture, what is the most common cause of that? Like, how does this happen?
Well, again, I think the 2 most common causes would be trauma to the tooth, or prior endodontic treatment. You know, it might be a large post that was placed following endodontic treatment, and traumatic occlusion that over time causes damage to the tooth, causes the fracture in the root of the tooth. So
Yeah, when I took my endodontic boards, there are quite a few studies that talk about, and Jason mentioned this, just endodontics being the cause of most vertical root fractures, which is probably the case. I mean, when we do a root canal on a tooth, we remove a lot of structure. So tooth isn't more brittle or anything like that, but structurally it is weaker. And a lot of these individuals that end up with a fracture, they're functioning their function as far as occlusion and stuff is typically pretty hard on the tooth. So you have these individuals that are grinding, clenching, and then you remove tooth structure, and that's where most of the vertical root fractures probably come from, aside from the trauma and those other things. So root canal is probably one of the top answers there.
So just a few additional diagnostics to consider as you are looking at cracked teeth in your practice. Removal of the restoration is going to be an important tool to help you determine the extent of a crack. And that might be during endodontic treatment, or that might be just during maybe a crown prep or replacement of a restoration. Staining of a crack can also be helpful to help you visualize it. We use some methylene blue and stain the tooth and allow you to see that. We talked about transillumination. We talked a little bit about probing. A deep, narrow periodontal pocket is the classic periodontal sign of a crack, fractured root. And magnification, always a very helpful, useful tool in trying to identify and see these cracks or fractures. And even sometimes a little surgical exposure sometimes will reveal the extent of a crack or a fracture in the tooth. So I can't stress enough, again, the importance of the endodontic diagnosis. It used to be, when I first got out of school, before we had cone beam, it was the classic J-shaped lesion that we used to determine if a tooth was cracked or fractured. And so this would be an example of that classic J-shaped lesion wrapping around the distal apex of that molar and up into the furcal area. And in this particular case, the endodontic diagnosis, very important. And once you learn that this is a necrotic tooth and the probings are normal, the recommended treatment was endodontics rather than assuming a split root or a cracked root. And so endodontic treatment is completed. And then here's a 1-year post-op. So and this is what makes treating cracked teeth so challenging or difficult, because sometimes we'll see just some amazing healing on teeth that you would assume had to be damaged, and vice versa. Sometimes you'll do a beautiful root canal and you'll continue to have symptoms if there's a crack that you just weren't able to see or diagnose. 3D imaging is just an amazing tool that we're using now. I have to say, we started using 3D imaging in 2011, so I guess this is our 10th year, and it took a long time, I think, to get to the point where we feel like we can look at a 3D image alone and know with confidence if that root is cracked or fractured. And I feel like that came by taking a lot of scans and then opening up teeth and trying to correlate what I saw under the microscope with what I saw in the 3D imaging. But the imaging is really a key diagnostic tool now in helping us determine if a tooth is restorable because of a cracked root or not. Jason and Matt, Fleur, do you guys have any thing you'd like to share about 3D imaging and helping you to diagnose and treat cracked teeth?
It is pretty amazing when you can see on a CBCT scan, and it gives us so much guidance with fractures as to being able to diagnose it and quite frankly, not go into some of these teeth that before we were going into and attempting root canals or retreatments on. So
Yeah, it really can save the patient a lot of time and money, and I think it's beneficial to them overall.
One of the things that's unique about our imaging too is we have what's called a focus field CT. It's different from most of the CTs that most of you are considering in your practices because it really only scans a quadrant at a time. And in doing so has just really high resolution. So sometimes patients will show up to our practice with a 3D image from another practice, and we'll open that up and realize it's a full volume scan, and the image quality is just not enough to really make that diagnosis. So oftentimes we'll end up scanning, rescanning a patient because the ability that we're able to see using our imaging equipment.
Jason, I'll say too, I actually have had a couple cases recently where radiographically it looked like maybe there was radiolucency mid-root laterally, and but not definitive. Take a scan, and sure enough, there's lucency alongside the root, nothing apically. And that to me is like, yeah, there's a crack somewhere within that root. So had I gone in, patient's symptomatic, I don't see an apical lesion, but had I gone in and retreated that, I don't think it would actually resolve her chief complaint ultimately.
That's a great point. Thanks, Fleur. In this image here, you can see, we wish all fractures were this easy to see. In that upper left quadrant, you can see literally the palatal root, the pieces of the root began to separate. I explain to patients, as I said before, most of the time we don't see the fracture in the root, we see the changes in the bone adjacent to the tooth that tell us that the root is cracked or fractured. This happens to be my mother-in-law, and she had this root canal 25 years earlier. And she came in and I took a scan of this tooth, and you can see some classic radiographic findings that indicate that the root is fractured. If you look closely, you can see the lateral bone loss on the mesiobuccal root. In the upper right quadrant, you can see how it's a narrow defect that wraps around the corner of the mesiobuccal root. So you can see the breakdown of the bone on the buccal here. You can see from this slice the extent of that deep, narrow perio pocket or breakdown of the bone, and how the bone loss wraps around just the mesiobuccal part of it. Classic sign, classic findings in CT of a cracked root. Because it was my mother-in-law, I opened it up and looked too, and sure enough, there you can see internally the crack inside the tooth. In this case, this patient had a 6mm probing. So we took a scan, and as you look at the 3D image, again, this shows you the quality of our scan, which I just don't see in a lot of other full volume scans. And you can see the extent of the bone loss. If you look in the lower left quadrant, look at how the buccal bone has not only receded along the buccal surface, but it's even pulling away in that apical third. That's a classic sign of a fractured root there. And when this tooth was opened up, we could see that as well. So just a little bit about prevention of getting to the point where these teeth are non-savable. I think we need to watch for patterns. If we see multiple cracks in the teeth, if we see multiple cusps that are fracturing off, these are patients that we need to be a little more aggressive with, perhaps in our treatment of cracks. And watching for patterns, wear patterns that would suggest occlusal trauma and parafunctional habits are really important. This is a patient, when we talk about patterns that had come to our practice over the years, she had a root canal there on 14, And when she came back, and 7 years later, that tooth was gone and an implant had been placed. I don't know the full story. I'm assuming that the tooth fractured and was removed. But the same patient in 2010, when we looked down at number 18, she had some cracks there at that time. And in 2014, she had a split tooth on the upper as well. So this patient certainly has a pattern of traumatic damage to these teeth. And so one that probably needs to be treated a little bit more aggressively. And then on the other hand, here you'll have a patient like this who's been asymptomatic forever. No response to normal percussion, no response to cold, but this tooth number 8 with a visible crack with staining is testing normal to EPT, right? And so you scratch your head, you say, how does this last for so long without any problem? Another patient, same kind of thing. This was a football injury 40 years earlier. A crack that's big enough to open up, but yet this tooth is asymptomatic and functioning for years. So just when you think you can put everybody in a box and categorize every situation, just a quick reminder, you can't. So here's our final exam. These are some different types of cracks we've talked about. We've got a vertical root fracture. We've got the fractured cusp. We've got the crazed line. We've got the cracked tooth. And understanding and each one of these is important. And it's also important that we practice using the right terminology. I'll admit that even as the endodontist, it's sometimes we inadvertently exchange the terms cracks and fractures, and that can create confusion. So it's important that we try to be very clear in our communications with each other. And so my thought was, well, what can you take for your practice tomorrow? Here are a few things that I think you should take home with you. Cracks only get worse. They don't go away. They'll either stay the same or they'll get worse. Earlier that we can get cuspal coverage to prevent a cusp fracture, the better chance we'll be able to save teeth from non-restorable situation. Remember that 80% of cracked teeth, if the pulp is vital, they won't need a root canal if you crown them. We need to watch for patterns, and if they have cracks in one tooth, they probably have cracks in others, and we need to consider, treating those cracks. And if they have parafunctional habits, perhaps, address that, night guards and occlusal adjustments. So a few things that we think you can use in your practice tomorrow. We appreciate working with all of you. We are successful because you are successful, and we really consider all of you our partners, and we appreciate the chance that we get to see your patients and to help you provide care for your patients. So with that being said, are there any questions on any topic that we've talked about tonight? Okay. Any other questions? Okay. Well, that ends our presentation. We appreciate all of you for coming and participating.
Thank
That's
you,
next.
everyone. You guys
Thanks,
are wonderful.
everybody.
We love working with you. Thank you.